You see, it's on my scrub.
You see? You see?
All right, so I think we can start. Yep.
Perfect.
So, good evening, everyone. Once again, this is Rolandas from Megagen, and thanks for taking your time to join our Megagen webinars. Today, we are honored to have Dr. Marcus Engelschalk and Dr. Miltiadis Mitsias as our guest speakers with the topic short implant therapy, success, survival, and differences. Dr. Engelschalk is the chairman of Megagen Germany and ambassador of Slow Dentistry in Germany. He is an international lecturer on implantology, laser dentistry, IOS, and CAD/CAM in implantology. Our next panel speaker is already well known for his excellent work and lectures on the root membrane technique. And with that, you already may guess that we have Dr. Miltiadis Mitsias as our second speaker. Dr. Mitsias graduated Dental University in Athens and works there as an instructor in prosthodontics. He's a Megagen ambassador and an active international lecturer and author of many scientific papers. As this event is live, we're going to collect all your questions at the Q&A section, so please do not hesitate and ask whatever you want to the speakers. And afterwards, at the end of this session, both of the speakers are going to answer all of your questions. So, Dr. Mitsias and Dr. Marcus, let me hand you over this, and the stage is yours.
Thank you so much for the invitation. I'm super excited actually that we're doing this first attempt of giving this webinar together with my really good friend Marcus. It's an initial start of many things that we are working and we're preparing for the near future. So we decided to do something together. It's like a baby because you know, it's a topic that none of us has ever spoken. So we started together to work on this project from scratch. We had 0 slides. So we collected a lot of material here and there. We tried to be as much scientific as possible and to give answers back. Marcus?
Yeah, hello from my side also. It's a really pleasure to be here and to share this next hour with my dear friend. Yeah, as you already told, it's a first time for us to talk together on a virtual stage, and I hope we will have chance to talk on a real stage in the future together for many times. And we choose this topic because this topic is very interesting, and also we're doing it in our offices for years now. We didn't lecture about this, and I thought this should be a good idea to talk about also some different things than we usually do, like root membrane or digital. And when we faced this topic, the first question which always came up or popped up is, do we need them, or why should we use short implants? And this is the first question I want to ask you. Why do we need short implants? What do you think?
Well, obviously, it's the question that most of the people have, and then the other question comes is the why. So why do we need these short ones, especially when we have, you know, so many techniques for augmentation, horizontal, vertical, so many lifts here and there, and that we see. So is there a need? This is actually the question. Do we have this need in 2020? And the answer is yes, definitely a yes, because as we see, the GBR, advanced GBR with simultaneous implant placement have shown many post-operative complications. And we see this every day. We haven't solved our problems. On the other hand, especially in maxilla, we see that the zygomatic implants are not being used with the frequency that we want. And also we have an increase in the complication rate for all of them. Also, talking about the mandible, in the mandible, it's, as you know better than me, the vertical, okay, increase of height is completely unpredictable. So the use of a 6 or a 5 or a 4 millimeter implant really gives a lot of solution to the problem. There is a paper that we quoted here in a population of 431 65-year-olds. It was found that the placement of an at least 6 millimeter length was possible in the lateral part of the maxilla in a very small percent, and in only 50% of the mandible cases in the lateral zone. So this shows exactly the need that we have in order to use this short implant. But background. So is this something new? We know that this is not something new, and it has started many years ago. And studies have demonstrated greater success in short implants in the mandible and the maxilla, especially with the augmented areas. Now, we prepared a small historical background as we did our own research. And in the timeline that we saw, this thing is not only it's not new, but it started in 1968 with Thomas Driscoll and the Bicon implants. At that time, these implants were 8 millimeters. So imagine back in the 1970s, 8 millimeter implant, this was like so tiny. You know, I want to tell you a story. First time I placed my first implant, it was NYU, it was 2001. So together at time with Dr. Elian and Dr. Tarno. So Dr. Elian took my hand, you know, it's my first implant. So it's really, I was shaking, you know, my heart was like 150 beats like during a marathon. So I was trying to drill, you know, my hand was going like this. I think originally the plan was to place a 4 millimeter by 8.5. Finally, we placed the 5 because, you know, I had over drilled, obviously, the osteotomy. And then when I saw the 8.5 implant, at that time it was osteotype 3I. So we hadn't been inside Megagen world. So when I placed it inside, I asked Nick, I said, Dr. Elian, are you sure this is gonna handle? I mean, this is gonna be enough for the crowd, you know, it looks so short. She told me, no, the study shows that we think it's gonna be fine. So anyway, going back to this, we're saying that the evolution from, it goes from Driscoll to Bernmark in 1979, but then our semi-god Kwampa Park came in 2002 with the rescue implants. So I'll tell you another story. So when I came back from US, I was going to Dr. Shorba's practice. So at that time, we didn't really have a representative of Megagen in Greece, and he was bringing Megagen on his own. Imagine how thrown he was. So he showed me the rescue implants at that time. 6x6, 6x7, 6x7x7, 7x8, huge. So I told him, what are these things? These look like bombers, you know? I said, he told me, look at this, you learn now, you young kid. And I was fascinated, Marco, you can't believe, I was really fascinated. This was unbelievable. You know, he was taking out the motors, and when there was no, in the middle bone, you know, in between the roots, he was placing like 7x7, or 7.5x7, or 7.5x8. And he could do it, you know, he could really do it. He could place an implant with immediate placement and stability, like 30 newtons. I was shocked at that time. Then we have a new Bicon entry in 2008 with their 5 millimeters. So we see that the companies decrease the length. And then again, we have the 4 millimeter by Straumann and Rock Solid, and they introduced their concept, if you remember. We will speak about this later. And again, after, we have the new AnyReach with the 5 and the 6 millimeters now, that we really go to a different level of osseointegration and immediate placement. Now, I placed this picture because, you know, we were talking about this. What is short, actually, you know? I mean, who is the shortest and what is short? So please tell me what's your opinion about the short?
Okay, now it's a question if we talk about short implants, and I think that was best funny pictures we could get to compare the lengths. So the most important topic now is how short should an implant be? And if we go to the next slide with the measurements, then we can see there is, going into the literature, we can see that there are some recommendations for the lengths. And we can say nowadays ultra short has been seen 4 to up to 6 millimeters, which is quite very short. And we will get some construction problems, but we will talk about this later if we talk about again about the lengths and the internal and external hex, because 4 millimeters is not that easy. The next short one is 6 to 8 millimeters, as we can see in the study, or around 5 to 9 millimeters. And I would say as a standard implant, we can now talk about 10 millimeters or more. And if you look at this long-term systemic review and meta-analysis, we can see that they used mainly articles with implants between 5 and 9 millimeters. And this gives us the first hint how long can a short implant be. And on the next slide, you can see there it's perfectly done by the colors, that also there they looked at implants with a length of 5 up to 7. And finally, the diameter of the implants was between 3.75 and 6. So there should be something like a secret between the diameter and the length. And I think if we look at the length of implants, and when I can also tell a story from my beginning in 1996, 1997, when I started learning to do implants, I was taught on implants 50 millimeters, 30 millimeters, but then we had the discussion of cooling during the drilling and all these things. And I think now 10 millimeters between 30 millimeters should be a range we can use, but for the shorts, it's always a question. And if you look at this beautiful picture now, we can see we have 2 implants with 5 millimeter lengths and one with 8. And now the bone is determining a little bit the length, because as you already told us in the beginning of this lecture, it's a question, do we want to augment or not? Do we want to avoid something? And if we don't have this much amount of bone, then we should use a small implant. And I think
you said it very nicely, because it's, if we want to augment, but sometimes we cannot even do that.
Yes, yes. As you told in the lower jaw, you already did. In the lower jaw, it's always difficult to augment the height, because sometimes we're not able, even with the best concepts. And the next thing is, if we have a concept, is it working in everybody's hand? So that's the big question. Yeah?
Absolutely, you're so right. You're so right. So tell us about please, the diameter. What do you think?
Yes, diameter. I already mentioned it. Diameter is also something very important, because if we think the surface of an implant, it's very important to get the bone grown onto the implant, to get this bone implant contact. And if you have a small area or a small surface, then that's difficult. We should do something else to make the surface bigger for the implant. And that's roughen the surface. That's a special kind of threads. And if we look to the slides with just, if you can go one slide forward, yes, the slides with the comparing of the implants, and we see we have our normal lengths, we have our any-rich implant system, which have its own theory about how we can design an implant. And just go one slide back, please. I was too lazy. No, not just yes, this one. Here we can see perfectly, because you see it's our philosophy of the threads. And even with this perfect thread philosophy we have with the any-rich system, there is another kind of shape for the rescue implant, because you can't be that aggressive with the thread anymore in this diameter if we talk about 6 or 7. And if you compare this with the standard plus short implant by Straumann, you see they changed their threads, and with that they changed the surface. And if we go now one slide forward, and again we saw this with the calculation. This reminds me to my school times, where you have to calculate the surface of the cylinder. Yeah, of course, if you shorten up your implant, and you're increasing the diameter, then you get the same kind of surface. And this is why they
Marcus, is there a relationship that we can say that, you know, if we reduce, let's say, a millimeter, then we have to increase the diameter? How should a clinician, let's say, try to estimate or to calculate, let's say, if I use an 8 or a 7, how much should I increase this? I mean, this is a very important thing. And as an excellent surgeon, please give us your comments on this.
Well, thanks. I'm not that excellent like you, but if we do all the same things in our daily office, and the thing is, if we are placing an implant, or if we are looking for the available bone we have in a case, then it's very important that we still have bone around the implant, because the bone needs nutrition, and the implant needs the bone to be kept in the bone. So you can't rise the diameter as far as you like, because as you perfectly told us, your first case is with extracting teeth and putting in 7mm diameter implants into an extraction socket, then you need the bone for that. And I think we all should be aware that if we shrink the length and we want to increase the diameter, we need the bone for this increased diameter. So this is maybe very important. And when we looked into the literature, it was very funny, because we saw both sides. We saw a study which told us increasing the diameter means increasing risks. So if we go to the next slide, we can see the study we found in the literature. So that's something very unusual. And on the other hand, we see that if you increase the surface by increasing the diameter and shrinking the length, then you get more bone to implant contact, which is very important for us, because we need the support of the bone, especially for these short implants. And we will see later the problems with maybe problems with the crown to implant ratio, because if you shrink your implant length, the crown will be the same. So this is also physics we have to respect. And with that, we can see that we need to rise up the surface. And this is only possible if we shrink the length, we have to rise the diameter. So this is something we can resume from the whole thing. And then we see that the increased diameter can work better with the distributing forces on the implant, because forces on the implant also should be given to the bone, and the bone has to react. That's very important. And for me, that's one of the first very important messages for this seminar today, is you have to respect the bone, not only in the depth or in the widths. You have to calculate how deep I can put my implant in, how much I have available as a length, and in the width. So this is very important. Even if you use small implants, respect the bone. And if we look now to a possible treatment plan, so what do you think? There are a lot of concepts in the world of implantology. And when I think about the concept of Malo or something like that, what do you think? Can we use it both, or is there advantage or disadvantage in this case, Miltiadis?
I think that, first of all, I agree with you completely that we can increase the diameter, but up to a point. Because, you know, increasing and increasing in order to get the initial stability and then have less than a millimeter, let's say, of circumferential bone doesn't work. We will have consequences. So yes, in increasing the diameter, but on the other hand, we really need to be careful, and we need to leave at least 2 millimeters of bone in order to have the proper nutrition. Now, this is a typical scheme that we have here, and actually this is what we all see every day in our clinics, in our practices. People that they come with compromised ridges, you know, and extractions that they occurred many years back, and they didn't do, maybe they didn't know the socket preservation, or they couldn't do at that time, they could not afford to have a surgical intervention, or for many reasons. But we see very difficult cases. So in cases like this, when we have really deficient ridges, I think that the use of short implants is it's a fantastic solution for me. I use them as often as I can, especially 8 or 7s, you know, if I can, either in the maxilla or in the mandible. And I have to tell you that if you do, as you said, if you do a proper placement and you respect the bony housing, especially with the drilling, especially if we do drilling, you know, in wide implants, the drilling of with 5, let's say, millimeter drill or 5.5 drill, it's really much more aggressive than with the 2 or with 3. So, but if you do a proper drilling and you respect the bony housing, then you can really have fantastic results. Now, here you can use also kind of, let's say, indirect malo or kind of beveled implants with different type of multi-abutments, and you can extend, okay, more to the molars with the use of a short implants or 2 short implants, and provide to your patient not only a first molar occlusion, but the second molar occlusion. So we see this, and this is a case from Pamban Park that we have seen it many times, but really demonstrates here the problems that we have with less than 9 or 8 or 7 or 5, let's say, millimeters. And how could you do this with these bony limits? Either you should go for a vertical augmentation, and we know that this is, for me, this is one of my worst procedures, completely unpredictable. So I leave it to the ones that they really do it well. I don't know if it works in your hands, but in my hands, it's not so good. So I really go there with a short implant or 2 short implants or 3 short implants that I can splint them together and provide to my patient what he needs. And this is how the case finishes. And we can see also a combination of standard, let's say, implant with 2 other short implants, splinted or non-splinted. And you will tell us after about the splinting, because this is a question also that we get, and it's very important. And we really don't know the answer to this, even with the standard implants. And a lot of people are saying, you know, splint them. Other people say don't splint them. The literature shows different and controversial articles. Now, long-term observations have shown the survival rate of 99%. Okay, that's super high, and 99.5 for longer implants. And for shorter examination periods, this goes to 98.2, with the other implants nearly to 100. So I think that the success rate and the survival rates that we get are equivalent to the standard implant length. And especially if we compare them with the augmented areas of the standardized implant, I think that the survival rate of the short implants might be even higher. Now, we were talking before about the stress, and this is something with increasing diameter that we get in the bony housing. So what's your opinion about this?
Well, the stress is a big issue. The thing, as you already mentioned, splinted or not splinted, and just having 40 minutes today to talk with you together about these topics, we roughly can talk about screwed or cemented, platform switching or not. These are all factors influencing also the stress, because the load of the implant and the time of loading, do we can load them immediately or after a healing period? Should we heal for the lower 3 months, for the upper 6 months or not? These are always questions on the stress, and we just can roughly touch these topics. but stress is very important. And we can see in the literature that there is something with stress on short implants. And if you increase the diameter, then you can work on the stress a little bit, effective. You can reduce the strain, which is very important. But sometimes you can't really reduce the stress on the implants. And it's depending also on the direction of the load. Because looking at chewing on implants, on short implants, long implants, the crown-to-implant ratio is always influence us. And it's very important to see, because yes, of course, if you look at this literature, it's clear that if we load an implant, if we bite on it and we have a long implant, and normally we use them with 10 or 12 millimeters, and then we shift to 5 millimeters, then there should be something with the stress. And finally, I laughed a little bit when you talk, yes, I'm using small implants a lot in my office with 8 millimeters. Honestly, 8 millimeters for me today, it's still a normal implant, because 8.5 we use a lot if we don't have the amount of bone we need and we don't want to augment. But talking about 5 millimeters sometimes, this is very, very difficult. And then we have to see that we have enough bone, as you already mentioned with me together. Enough bone should be the key, and looking at the bone, how we drill, because drilling for a short and wider implant means you use a lot of drills. And I don't know what's your experience, but my experience is if the implant diameter gets wider, drilling is not that easy. It's become sometimes a little bit more difficult, because the drills for wider implants, they're rough. I don't know what's your opinion, but that's the
I completely agree with you. I mean, especially when the diameter increases, and the drilling process, sometimes it becomes uncomfortable. Let's say with drills over 4.5 to 5 and 5.5, sometimes 6, 5.9. Let's say it's. I still remember when we were doing a lit review back in the university that the complication or the iatrogenic mistake that we as surgeons we can do with increasing the next drill increases logarithmically. Mm-hmm. So it's like a curve that goes high up, and I always have this in my mind. As the drills are processing, I'm very, very, very careful in how to use them. And I think there is a game here of playing with the bone density in the maxilla, let's say, under drilling. And I think it comes with experience also, as you said. But always, we really have to respect the biology and what's going on with the bone housing, and respect the parameters that others have given over time. Not only that, we need to have also the stress in our minds. How do we place the implants? We all want to have initial stability, but sometimes, with increasing diameter, things might be difficult also, especially in the hard bone, or what we see many times in the mandible, let's say. I've seen many times strong bone, in type 2, let's say, in the mandible. So with the new technology implants like AnyReach, for example, we need to be careful, and we need to see how much stress we should apply to the implant and to the bone also, because problems can arise not only to the bone but to the implant itself.
Yeah.
And we're having a discussion with Guido Turki about this, and he had some wonderful pictures showing that we really should not exceed implant placement more than 60 newtons actually. Mm-hmm. So we rised up with as much torque as you can give to the implant. It's the best, but this doesn't this belongs to the past. That doesn't belong to the present. So let's see about the success rate. What's going on? Because a lot of people are asking, what's going on with this? I mean, are they going to last? And I have here a paper that we presented in the EAO back in 2011, I think it was. This we did with Dr. Shorbas and Helen and Jonathan Mills at that time. This is with rescue implants. And this is from our practice. And we gave, after 4 years, a 98.2%. And I really think that this is a really good number. And as far as I've seen from our patients, we do not have problems. And I think it would be a great idea if we could collect these cases again and provide like a 10-year now or more than 10-year result. This was very, very promising. But what I see, and these are many papers that we collected, we see that these numbers are equivalent with what the literature is providing to us. We are saying 93.8, 92.3 after 10 years, survival rates of 95.5 after 5. None of the 30 implants here from Freiburg was lost. And Renoir gave, oh, did I tell you the story with Renoir? You know, Renoir was the first guy that I was a student. So at that time, you know, it was an AO in US, and I went to see the AO. You know, for us students back in 2002, AO was, you know, something, you know, phenomenal.
Yeah. Still
2,000 people inside, you know, Boston was really something. And the first guy that I saw speaking about this was Francois Renaud. And, you know, I think 2002, 3, something like this. And he was speaking about the short implants, and they asked him about, you know, the crown-to-implant ratio and all of these questions, you know. And the guy gave a fantastic speech. And also he gave details because he was a mechanic. So from aerospace, so he showed that really the crown-to-implant ratio is not, you know, so much of a problem. Then the problem is to use the proper implant length and diameter instead of considering, you know, the implant to crown ratio that you're going to speak after. But it was a magic time, you know. I really saw this, and it opened a new horizon for me. Now, for me, to make the story short, the survival rate and the numbers that we have are equivalent almost to standard implants. And here we see also a survival rate, 914 implants of 88.1 after 168 months, comparison with 86.7. So really, wherever you're going to see, the numbers are equivalent. Yeah. Now, would you like to talk to us about this slide and the significant difference that was found?
Yeah, and when I saw this study the first time, it was very interesting because when we talked about stress before, we have to talk about the quality of the bone, and not only around one implant. It's also very interesting to see the quality of the bone between implants. And well, in this study, they measured and they had a look on different times. They looked preoperative, some weeks later, some months later, and then they saw that the success differs on the time you look at it. And by listening to you now lecturing on our common topic, there's so many things I got in mind, and I think we can sum up now the first half of or the first part of our lecture, that there is a huge success for short implants, but it depends on the bone also hardly, and it depends on the way how we treat the bone. And for example, in this study, if we see the 2 implants placed, and imagine if you place them too narrow to each other, then it's clear that they will fail. And this has nothing to do with short or long, because we have to give the bone around the implants the place, the air to breathe, as whatever you will call it. And I think this is very important, that if you place short implants, you have to respect this. And this leads us to the general principles, how we can do this. And it's now time to have a look on some cases. And yeah, it's obvious normally in the upper jaw with the sinus and the reduced amount of bone you have often after extraction. Because if we talk about patients with short implants needed, then it's not the young, healthy, 24 age young adult. It's the old one. funnily, if you talked about drilling and your experience with the drills, if you drill in a 72 years old medicortical mandible, then this is often the case you have to treat with these short implants. This is the thing we have to respect. So if you look at this case, it's your case. You've done it. You did the picture.
Actually, this is a this is a Constantine case when we were trying to do with the Eneridge implant, when they sent it to us to try it and to test it, and we're thankful to Megagen at one part. We can do it also flapless. So we like to treat flapless cases, especially when there's a lot of keratinized tissue, and we have a lot of horizontal width also, and we can place the implants like this, guided or freehand. Really depends on the case. Here you see that you can do this is a double case on the right and the left, actually, with minimal bony housing. As you see here, it's almost nothing. So Constantine Shorbas that did the surgery here, I mean, especially if you look at the area of 20s, this is like a small miracle. That we used also augmentation and placing the implants. At that time, it looked to me like the cases that the great Zygmunt Zor is showing. With only 2 or 3 millimeters, that he manages always to place an implant somewhere there. So this looks to me like this. And when he did that, I thought, this is unbelievable, and I really felt extremely nice that we have these short implants and these small magic implants that they can really do the job for us, and and we can be the magician. Here's the CAT scan picture also, and you see the augmentation and the bone inside. This is the prosthesis that we did. I did this prosthesis with the lab of Michael Papastamos, and you see the emergence profile also, because the implants are wider also, they provide to us a more horizontal space, so we can start from a different point. And here you can see also the occlusal picture of the case, screw-retained. And the case now, it's more than 6 years, as you can see here, really going well, no bone loss, everything is there, and patient is happy. And the funny thing is that we did a very difficult case for this patient. Patient is happy. There was no augmentation, no real augmentation, some crestal lift, nothing. And imagine that we didn't have the burst, the new type of compressive burst that they do the reverse. So we couldn't really send the bone up with the denser burst that we all are using right now, this hydraulic pressure. If we had it at that time, definitely we would have used it. But even though without them, we managed to do the case, and the case is 6 years after, with no lateral window, no this, no that. So really goes well. Now, tell us about this video with this Eneridge from Dr. Park Super RBM surface implant.
Yes, that's very easy. We prepared 2 videos. This is the first video, and you can see that in this case we have class 1, which means we define the heights and the width with lower than 6 and lower than 10 millimeters. And this is very important to see that we can use the existing bone perfectly. On the other hand, on the right side, you see the video where there is an augmentation. And yes, of course, we all are trained now doing augmentations and do sinus elevations. For me, the question is, and we will see this later in the literature again, is that if we do augmentation, yes, of course, we can gain bone. It's no problem. We have to wait a little bit longer. And after some months, we have more bone. We can put in more implants or longer implants. But the question is, do we have more failures, or is this connected to failures just because of the augmentation? And I think we have to say clear yes in this case, so that using the short implants like on the left video is really important to take it in our daily office. So it's a very important thing. But looking at these pictures now, I would say besides using the short implants, maybe it's more important to use things like R2Gate, using digital things, digital planning things, guided implantology, in these cases, I would recommend this warmly, not only because I'm a digital man, but also because I think it's very important. So in this case, you see this short bicon and you see this Megagen implant. Now, I think it's evident to use something guided. What do you think?
Yeah, I'm totally with you, and I agree in everything you have said, and also for the use of R2Gate or any other digital type of system, especially when you're dealing with such a delicate ridges. You know, I mean, they're so tiny sometimes that using these digital new instruments that we have, and also trying to, you know, sometimes it's good to speed up, but sometimes maybe slow digital dentistry is better to be used here. And here also we can see the different combinations that we have. This is an immediate placement. We did, again, Constantine did that back in 2010 or 11, I think it was 11. So these hopeless teeth were out, and I told him, okay, let's do a lateral window. And he told me, no, we're going to place 2 short implants and we'll be great. And I told him, come on, I mean, who is here the conservative one? Are you or me? How old are you? And you know, I was the conservative, and I was like 30-something years old, and he was the one that he was showing me the future again. And you know, he was right. Look at this. This is 2017, 6 years after loading. I'm still there. Everything great. You know, it's working beautifully. No reason to have a lateral window. And also here, with or without crestal lift. Sometimes we can use a short implant with a very minimal crestal lift. You don't need to, you know, to go more than 2-3 millimeters, let's say, if this is what it misses. So it's good always to get more bone, but as we know, over time, the you know, if you really cannot do a big lateral window and you do a crestal lift, you might have also absorbance of materials throughout the years. So maybe playing safe is even better. So as we see here from 2008 to 2011, we still have good results. Something else that we're doing, we are combining, you know, a standard type of implant with a short one. And here you can see 9 years after, 3, 5, 9 years after of this combination, it's a hybrid or combination type of lengths, that everything is there, functionable, everything is going really well. And you know, the most important always for me is to provide solution for the patient, because the patients come to our practices and they really don't say, have they ever tell you, Dr. Engelschalk, could you please place a short implant? Or have they ever tell you, you know, please use, in my case, a 7x7, or please do a lateral window, or please, no, they come and say, you know, Marcus, I want to have my teeth back. I really, you know, that's what I'm paying you. That's what I'm coming. And, you know, I want to pay the less, I want to stay the less, and I want to leave from your clinic as soon as possible. With teeth, if you can do that, would be great. So,
and time is also for them very important, because
of course.
Yeah.
So tell us about the lower arch, and what's your opinion about the mandible?
Well, I already told you that my success rate in the lower was much more higher than in the maxilla, and we have to deal with the nerve. I think that's the border underneath the soft tissue, and we have to deal with the sizes of implants we can place. And I think if we talk about concepts for the lower arch, we later also have to talk about splinted, because we need as much support as we can get. And this is also for something like all-on-4, or if you do something like this with a removable on small implants, then it's a question of the available bone we have and the idea we have for how we want to reconstruct everything. And in cases like this, I'm sorry not to have a picture of the corresponding upper jaw, because it's also important what is in the upper jaw? Which reconstruction do we have? Do we have fixed teeth, fixed reconstruction? Do we have a removable? What about the pressure on this reconstruction? And these are all factors influencing our ideas how and where to place short implants or implants itself. And I think this is very, very important. And
over time, we have seen many different concepts also coming up. We can see fixed partial dentures, couples, singles, combine them one-piece implants also, and we have seen a combination in a full arch scheme of short implants, and some of them with a normal length or standardized in combination with a short one in the back. We know also Straumann came up in EAO with a 4 millimeter standard, and we're saying this because this is the shortest we have seen so far. A lot of people are afraid of using them, and I understand this. Nevertheless, they gave some 93.5% after 5 years. What's your opinion about this? I mean, do you buy this? You really think, would you use this?
No, I never.
I don't know. And to be honest, I don't know. I might be, too short. Maybe 3 implants in a row, as they show, with three premolars, maybe could work something out. But I don't know. Do you think it's risky?
Yeah, I think it's a little bit risky. But honestly, if you look at this implant and you look at these dimensions, yes, you have 4 millimeters of implant in the bone. But it's like a tulip they have above, like their old first implant they designed. And if you measure the whole implant length with the tulip, because then we have to see where is the crown to implant ratio be measured at these kinds of implants. Then it's like a 6 millimeter implant, because you have to have a look on the whole structure of this implant. I'm not sure about this, but I never placed a comment.
As we know, evolution and technology continues, and here we see the new proposal from Megagen. Now it's the standard any region, any one implants with this really progressive thread design, and we have seen again, Pamba Park again surprises us, because if you see have this drill with this stopper ring, this is a rubber ring, and this guy is unbelievable. It's always, surprising us with new concepts and showing us the way. So here we can see a 5 and a 6.2 millimeter implant. If you see here, look at the end of it. How tiny is this? The 0.2. So defensive is there in comparison with the rest of the implant. If you have these 6 millimeters of length, and this one, yes, with this I could go very easy in the lower arch. Yeah. And also we can see a 5 millimeter in compromised reaches also in the lingual side in comparison with the buccal side. And you see that this is one piece, so it helps also a lot. And here we see different fixture diameters, and this is very useful, because we have from 3.5 to 5.5, and you can play ball with this. You can have a lot of them, and you can really play ball according to the socket for immediate placement, for top, for maxilla, for mandible. I really feel comfortable with this more than, let's say, 5 millimeters. For me, it's better. Not that I say something about the 4, but I found it, risky, let's say, in the placement. Maybe 3 it can work out, but for me it might be a little bit risky. Also, we see that, because we know now after years that there is a low arch drilling process, and they're suggesting us how to do it and how to use this new type of drills, also with a flattening drill that we can make more room for the 5 or 6 millimeter implant. Here's a case that we see again from Megagen. It's not our case. We haven't used this so far, to be honest, because they're very new, but we have to deliver the knowledge. And here you can see the limited vertical width and the placement of the 2 implants. And on the other side also, I think this is surgery by Dr. Park, if I'm right, you can see the flattering drill also that ensures the correct drilling, and this is very important to ensure the correct and accurate fixture placement. The single length stopper drill is very easy to use because there you can when you have 6 or 5 millimeters drill, the mistake is it can come very, very easy, So this drilling helps us very much. This is the suturing and the close-up. So please now, a lot of people are asking about the crown-to-implant ratio. This is the question for the short implants. So please enlighten this topic.
So we talked about this a lot today already, and that's a good bow now to come from our previous slides to this crown-to-implant ratio, even having this Straumann in mind, because this is a perfect picture to see. There's a huge crown with an abutment on a small implant, and to be honest, if we want to measure this, we have to see the crown-to-implant ratio is measured from the crown down to the screw of the abutment, because this is the whole part of the screw and the whole part of the crown. And looking into the literature, there are several numbers. They told us not to exceed numbers like 1.7 or 2.0. And if you go deeper and you see, we looked at a lot of literature and a lot of articles, you can assume that excessive crown-to-implant ratio could be a problem. Yes, of course. This is something we felt already. Then you see there are also studies, there is no crown-to-implant ratio influencing the marginal bone loss if you have even higher ratios like 2.4. But at the end, there is something like pocket depth. And there is, again, the bone which healed around the implant over the years. Is there any problem? But for me, in this topic, if we look to the next literature or to the next slide, we can see that there is really something important. We
talk about the diameter or the core of the implant plays a role in decreasing this 1.0, 1.7 or making it 1.5, let's say, or 2. If you have a 4x6 or if you have a 6x7, let's say, is it the same?
That's true. That we have discussed this already with the surface and the ratio. If we shrink the length and we increase the diameter, if you look in the literature, a lot of things are mixed up. And this brings me to the topic that I said, yeah, we need some more protection. Splinting is a protection because you support each other. And the next thing is, if we look then to the implants, if we look then to the studies, we see that the crown-to-implant ratio will get better. And this is something we see around the bone, that the bone has some problems with the stress, with the loading. And this is important. But if you go to the next, this is, for me, the most important slide in this discussion, because maybe the crown-to-implant ratio is not the right thing to measure. Maybe it's better to see the vertical distance between the occlusal plane and the alveolar bone level. This is something we have to talk about because the rest is inside the implant. And then we see more valuable results. And you see if it's higher than 50 millimeters, then we see more stress. And this is something we can use as a clinician because we can measure this. Nobody is calculating the ratio between the crown and the implant length, but something with 50 millimeters on a height we can measure. And the next thing is that we see that, yes, for extra short implants, there is also a risk, but at the end we can say that extra short, like 4 or 5 millimeters, or short implants, like 5 or 6 up to 8, are very good to use, that the success is like similar to normal. And having talked the word splinting already, we see that the non-splinted implants reconstruction in the posterior area have a lower success rate than the splinted. So there should be something like a support for implants smaller than or shorter than 10 millimeters. And I think this is something very important. And we see the cases, and if you remember the Park case, the last Park case, Dr. Park case we saw, was splinted. And there are various possibility how to splint or how to combine the implants and the prosthetic. And of course, if you have a cantilever, it's always a question, how long is the cantilever, which dimension the cantilever has, because then we have the question of load again. And load from a different angle. It's not only occlusal. That's very important for us. And the next
Tell
thing
us now, do we have these short implants? Do they come as one type of connection, or we can have the luxury to have them with different type of connections?
Yes, we have different kind of connection. I think the connection also is a secret for the success. And right at the beginning, when I told you about the 3 parts, short, ultra short, and long or normal implants, I told you 4 implants. Some companies have problems with the connections. And now we're coming to this topic, and it's good that you remind me to that. Otherwise, I nearly have forgotten it. If you see this, it's a short implant with an external hex connection. And the external hex connection in this case is just because they've not been able to manage the internal connection for this dimension of the implant. And with the external connection, we often have some problems. But in this case, when we did also the intro scan on this, in this case was a Biomed 3i with the encode abutment, we were able to do this also in a digital workflow. And if you go to the next slide, and you can see the abutment with the internal hex. I tried to do the picture of that. But external hex for us often is more a problem and to use. And we are used to have internal connections now. And I'm thankful for most of the implant companies producing the internal connection for us. And if we go on this workflow now, you see for the external connection, we need something like a splint to fixate the abutment before screwing it on the implant. Yes, of course, in this case, you can also say, can we do it screw retained? Yes, of course, you can do everything screw retained also, not cemented like in this case, was one of the earliest case I've done. But external hex is always something difficult, even if it's like a beauty like this, and you see the prefabricated milled part of the external hex are brilliant. But if you go to the clinical side, then it can be difficult. And the clinical side here, I don't know what's your opinion about external hex and platform switching, but I think we have to think about the fact that growing the diameter and the hex will stay the same. We have something like a platform switching with a huge platform being available. So what's your opinion on platform switching? Do you use it?
So, we know that platform switching works. I mean, and we know that we have seen it in all different companies with internal or with external, and we know also the studies from Canulo and from Luigi and other people also have shown this, and also Lynn Cavicius now with the zero bone loss concept has enlightened a lot this type of considerations. But in generally, I've stopped using external hex implants many years now, and I use only internal with a cone, definitely. We have worked also with Octa One, and we see very good results too. But to be honest, my favorite is the Morse taper, or with a really conic connection with an internal hex anti-rotational mechanism. Now here we see also the same phenomena, and I don't think that there is a big difference, and that's why we see also that we have implants nowadays from companies that they become with internal hex and not with external hex.
Yeah.
So as we see here, we have a lot of different options with internal or with external. And what do you think? Should we close this story for today, Marcus? Did we say enough?
Well, I think the time is running out now, but there's so much left to talk about, especially a topic like platform switching, whatever, is so important. And we did mention things, but I hope we could get a first view on the topic. And for me, having the new system from Mandibular available with nearly the same threads should be something to talk about in a year or whatever together. But yeah, take home message. Now it's time for a take home message and not boring the listener too much. What are our take home message? Start again. Just give us a hint.
You go.
Okay. Yeah, I think what I already mentioned, the complications in augmented posterior mandibles, for example. We have to respect this. And sometimes maybe it's better to place a short implant in these kind of cases because augmentation is not, it's not given to be a success. And let the bone augmentation material, doesn't matter what you're using, heal and become original bone is not promised. So this is the first thing. The second thing is,
I think splinting is obvious that splinting the prosthesis is associated with less technical complication, and this is a pathway that everyone should be following, especially with short implants and especially in the lower, in the distal areas.
Yeah.
As it says here, when it used correctly, the short implants achieve predictable, okay, and that's very important, predictable and promising outcomes, provided they're placed following a comprehensive and prosthetic protocol.
Yeah, that's true. And at the end, we can say that even if we have a complicated crown-to-implant ratio over 2, or if we do screw-retained crowns, or we have all these factors, the surgery, or we mentioned the drilling protocol, the loading, the type of prosthetic and the antagonist, and the follow-up, we can resume that we can use these implants very predictable, and it's a huge help for us in the daily office. Besides, it doesn't mean that we don't do augmentation anymore. Otherwise, I wouldn't know what to do in my office. But we have to use it as a possibility. Yes, that's the conclusion, I would say.
Very, very true. And with this, we would like to thank everyone, Rolanda, Sean, Dr. Park, Lauren, everyone for the invitation. I think that we covered for this first attempt in the short time we have the this really nice topic that we both were excited. More things to follow from us. We're working on many, many things, and we're looking forward to an even more fruitful future.
So you're not ready to go. Wait a second, Mitsias. We still have a couple of questions. So once again, thank you, Mitsias and Dr. Engelschalk, for your brilliant and really outstanding presentation. So we received several questions, so I really want to go through them. So one of the questions is about how about ratio between short implant fixture and the suprastructure? But as I think you already discussed about this, but maybe you have something to add, or any there a standard for success failure we should be aware of? This is what the dentists are asking.
Well, Mark, would you like to answer this?
Yeah, crown to implant ratio. We had in the study from Watzek from 2017, which is quite a new study. They told us not to exceed the ratio of over 1.7. And I think the other thing that I mentioned was this increased crown height space. And I think if you go higher than 15 millimeter with your crown height from the occlusal part to the bone level, then it's going to be risky. But underneath these two numbers, by literature, you are on a safe way.
Okay. Another question, which is, as I say, one of my favorite questions: what does Megagen short implants have advantages compared with other companies' short implants? So it looks like I typed the question, but it was from the dentist, not from me. So
I think that actually it's a very good question. I think that first of all, you have the luxury of using the unique thread design in comparison with. Nobody has this type of thread design. Everybody's trying to copy for the last 5 years Megagen in this knife edge thread design with the luxury of a short implant. Second, you have you can use it, the conic type of connection, which is very important. And third, I think it's a huge importance that they provide you with a drill protocol and with a standard and with a stopper drill that very few companies can give you. And this ensures you the precision of the drilling, which means the success of your implant. Yeah. So these three parameters for me are the most important in using this type of implant.
Okay, thank you. Also, what is the contraindications about short implants? So what kind of contraindications we have using while we're using them?
Marcus?
Yeah, I would say, first of all, it's the quality of the bone. The quality of the bone you have available in this region you want to place the implant. Of course, we have all these contraindication with health of the patient and things like that for normal, which are already given for normal implant lengths also. But beside that, if you have only a small amount of bone and you want to place a short implant, then you have to believe in the bone you have. And I think this is the most important thing. And even if it's not easy for us in Germany to use a CBDC scan, because we have to have an indication for the CBDC scan, and just placing an implant is not an indication to do the CBDC scan. In these cases, I would do it to judge the quality of the bone. And again, I have to mention R2Gate with the digital eye, that you are able to judge the quality of the bone right before surgery. And then if you decided to do the small implants or the short implants and you drill, and during the drilling, you get the feeling of the bone, you get the feeling what can you believe in this kind of bone? And do you have to change your drilling protocol by leaving out some drills, some diameters or not? These are, for me, the main important things, beside all the risk factors for normal implant placements.
Okay. It's not maybe a question or a comment, that some of the dentists are saying that external hex have better stability sitting on the platform, just because the sitting of the platform is larger. Yeah. So what do you think about that?
Personally,
how much time do I have?
Just up to 1 minute.
Well, personally, I don't believe this, and we've seen that we have many more problems in screw loosening with external hex than we have with internal hex. And for me, this is a no-no. I know that many times the external hex may be easier to use, okay, for a lot of people, and maybe they can correct, misplacements or whatever, which I understand. But for me, it's a one-way road. I do only internal. I'm not going with external hex.
Okay.
But this might be a personal preference. I mean, I don't know, Marcus, you have something to say on this or to comment?
Well, I'm completely agree with you. The thing is that there was a study in 7 years ago by Cyprich, which was a very, very perfect study about internal connection and external connections. And they did an X-ray movie on forces on implants and abutments. Yes, and there you can, this is the answer to this question, because then you can touch about the kind of internal connection and external connection. And I strongly, strongly believe to the internal connection. Yeah, this is, just look at this study from Cyprich.
And the last question was, what about the combination of D1 type of bone and the short implants regarding the vascularization, healing time, and the tricks for the improvements?
Again, I think that you can do this. This is very rare to find D1 quality, especially in the posterior area. It's really difficult. But if you can use this well and you can drill it with precision and to be, very gentle in how you drill in this D1 bone, you place the correct type of implant, I don't think that there is a problem there.
Anything to add? No. All right, perfect. So thank you for the answers. We really do appreciate them, I think, and all of the attendees as well. So thank you once again. Really, honestly, thank you from all of the Megagen family and thank you from all the attendees. The next Megagen webinar will be on May 15th. That means on upcoming Friday, when our guest speakers will be Dr. Sam Omar and dental technician Christian Betnarasu with the topic, the role of digital in the post-COVID-19 era, a clinician-technician approach. So I think it's going to be a very interesting discussion as well. So guys, please join our webinar as well on Friday. Thank you once again. And if you're more interested in our webinar program or recorded lectures, please visit our website, www.imegagen.com. So thank you once again. Stay safe. See you soon somewhere. Thank you, Dr. Marcus and Dr. Mitsias, for everything. And thank you, attendees, and see you soon.
Bye-bye.
Okay, bye-bye.